Well, good morning, good afternoon, good evening, everybody, wherever you are, and a very, very warm welcome to our second webinar to talk about the role of nurses and midwives in tackling antimicrobial resistance. Absolutely delighted to see you all. Thank you for coming back. If you joined us last time, I'm really pleased to see that we've had a huge amount of interest in this Global Solutions Initiative. And I hear today that we've had over 600 people registered to listen into this webinar today. So really overwhelmed by the support. It's a massive subject. It's really, really important. And the nurses and midwives of this world have a massive responsibility to be able to put their solutions to a really big problem. So thank you for joining us. Really great to see you all. Absolutely delighted to welcome back our fantastic speakers today. We're thrilled to welcome back Professor Hannah Balkley and her team from the AMR division at the WHO. Thank you so much for joining us. And in addition today, we've got 3 members of the Nursing Now Challenge who are going to talk to you about projects that we hope will inspire and excite you to develop your own. This is what it's all about. It's about you coming up with some fantastic solutions, and we look forward to hearing about those in the next few weeks. But first of all, I'm going to crack on, and I'm sure you all know our wonderful chief nurse very well by now. But if you don't, I'd like to introduce you to Elizabeth Iro, coming to us today live from the Cook Islands. Thank you so much, Elizabeth. Over to you.
Thank you very much, Emily. Good afternoon, colleagues, friends, and all members of the Nursing Now Challenge Global Solutions Network, and to our panel of experts. It's good to be with you once again, and I welcome those who are joining us for the first time. I have spoken many times about the need for nurses and midwives to be leaders across the world. Now more than ever, our leadership is needed to develop health systems that are accessible to everybody, wherever they live, who need medical and nursing care. Leadership is not just about a role in government or being a chief nurse. As a nurse, you are leaders at every step of your career. The roles that you undertake when you care for your patients, when you're teaching students, or when you play your part in a multidisciplinary team are all leadership roles. This AMR challenge will build on your leadership skills. Tackling a problem, working out a solution, bringing team members on board with you, and working out how to make sustainable changes are skills of every great leader. We will not find solutions to tackle the misuse and overuse of antibiotics without great leadership. By working together with colleagues from all healthcare disciplines, please share and grow your ideas and use your leadership skills to bring about the transformational change. Remember that big trees grow from small seeds, and your small seed may just be the solution we are looking for. I look forward to seeing what you will achieve. Thank you. Back to you, Emily.
Thank you very much, Elizabeth, and very much indeed. We hope to be growing some big trees from our small seeds as a result of this project and program. So thank you so much. Great words. Moving on now, I'm going to hand the baton straight over to Leanne Gonzalez to navigate us through the next session. Leanne, you will remember, joined us last time. Leanne is the Technical Officer for Awareness and Campaigns in the AMR division. And will help us, as I say, navigate our way through this massive global issue of AMR. Leanne, over to you. Thank you so much. And thank you to all your team for joining us today. I know we've got a lot of you here today, and it's a real privilege to be able to share your stories. Thank you.
Thank you so much, Emily, and thank you, Elizabeth. It's my pleasure to moderate this next session, which is going to run about 30 minutes. And we'll give you an opportunity to hear from a variety of people within the AMR division and WHO more broadly who work on this important issue. If we should have time for some questions after the technical presentations are done. So please put any questions you have in the Q&A, and we'll make sure that our group of experts have the opportunity to address these. I want to start off, though, moving straight into introducing our first speaker, who many of you will remember from the launch webinar, which I hope you got to see. It's Professor Hannah Balkley, who is the first appointed Assistant Director General for the Antimicrobial Resistance Division, or the AMR division, here at WHO's headquarters. Dr. Balke, over to you.
Thank you very much, Leanne. Thank you, Emily. Thank you, Elizabeth. It's really great being back here on this platform, and it gives me great pleasure to be joined by two other speakers from the WHO, which will dial into more focused areas. But as we said the last time, I think your leadership, and I want to reiterate what Elizabeth said, the leadership of nursing and midwifery around the world on lifting up the antimicrobial resistance agenda is extremely important. I'm extremely thrilled to be here with you today, and I'll give you a very slight presentation just for you to understand from a broader perspective. So we're going to zoom a little bit away out from the details of nursing and patient care to what are we talking about with AMR. The next slide, please. So the AMR division was established in 2019, yet bits and pieces of the response have already been present in the WHO, whether in HQ, regional offices, and in our country offices, because it's such a broad area. And I will talk about that a little bit. But the problem with AMR, as you can see, this is some of the data, and I'm happy to share these slides. You will be able to look at the details of the references. But if we zone into this, one child dies every 3 minutes. There's a reference on that. 1.3 million deaths attributable to AMR per year. That is from the IHME data. 28 million people living in poverty by 2050 from the Jim O'Neill report. 1 trillion additional healthcare costs by 2050, and 7.5% decline in livestock by 2050. The next slide, please. What these areas are trying to show, this is a slide that I can go over it very quickly, but this is from the IHME data report that came out in January of 2022, earlier this year. And for the first time through the IHME data based in Seattle, they were able to do a modeling process to look into existing data and a modeling process for areas for countries who do not have data, to see what is the actual burden of death in antimicrobial resistance. You can see here there are 6 or 7 pathogens that are accountable for 70%. And as nurses, as midwiferys, you will probably look into the fine print of these pathogens: E. coli, Staphylococcus aureus, Klebsiella pneumonia, Strep pneumo, Acinetobacter, Pseudomonas aeruginosa, and Mycobacterium tuberculosis. These are the top pathogens causing infections. Many of them are in the healthcare setting, but many are also enhanced transmission within the community. Only one among these pathogens that are in the headlines that has a vaccine, which is Streptococcus pneumonia. So to prevent these infections, the burden on hygiene is quite high. Next slide, please. This goes back to the burden that I had mentioned earlier on. All of you are probably familiar with the Sustainable Development Goal number 3, good health and well-being. But as I said, humans, food and feed, plant and crops, environment, terrestrial, aquatic animals, in all of these other areas outside of the human health sector, there is misuse of antimicrobials. There is use of antimicrobials to compensate for the deficiency in infection prevention and control. There is lack of knowledge on appropriate use in diagnosing a patient and giving them the right antibiotic. There is a limited amount of de-escalation once starting antimicrobials. There's so many areas that need to be tackled for us to truly bend the curve on the continuous rise of multi-drug resistance pathogens, whether in the human, food and feed, plant and crop environment, or the terrestrial and aquatic. All of these areas are going to significantly reduce progress in many of the SDGs, and not only the 3rd SDG, which is relevant to human health. Next slide, please. What we did earlier this year in anticipation of the leadership that needs to take place to bring together other sectors other than just health, but also the OIE, FAO, UNEP, not at the global level only, but also the representative ministerials at the country level. These 4 strategic priorities were published in, and it's available on our website. And you can see, you can read them: stepping up leadership, driving public health impact, research and development, and monitoring the burden and global response. And I think Leanne just kindly gave us a link on our chat. Next slide, please. Might be our last slide. So driving public health impact in every country. Next slide. This is just to show you that since 2015, the WHO, along with OIE and FAO, each in their different member state assemblies, have approved a global action plan. For the past 5 years, we've been monitoring it as a tripartite, quadripartite. 144 countries out of 194 countries have developed a national action plan. The sad part is only 25% have them appropriately costed. Zooming deep into how many of them have a national action plan committee, only 50 do, and only 2 of those 50 are from mid-low income countries. Next slide, please. The WHO has produced, and there's many more. This is just a very simple sampling of the different guidances that has been produced. One on WASH, IPC core components, stewardship, and you're going to hear a little bit more about some of these, and also laboratory strengthening. There's a wealth of many more documents available to support the implementation of the national action plans, and these require knowledge, staff, and skills on the ground to implement these guidances. Next slide, please. This is my last slide. Again, as I said, there's a lot to be said about the global coordination need on antimicrobial resistance in the multi-sectors, but you as a nursing career and midwifery, we will now zoom back into probably the human health issues related. We give more information in our quarterly produced AMR newsletter, and I think Leanne will also help put a link up there, and you can follow up on the work that we're doing along with our partners or at WHO. Thank you very much, and I hope you found this helpful. Leanne, back to you.
Thank you so much for setting the stage, Hanan. That was a very comprehensive presentation. I've posted links to some of the key documents that Professor Balki mentioned in the chat, and if you have any questions for her, please do add them to the Q&A. We move now to focusing on one of the many areas that the AMR division works on, which is antimicrobial stewardship. And so it's now my pleasure to introduce to you Dr. Solange Carolina Alves, who is the Technical Officer for Antimicrobial Stewardship and Behavior Change within the AMR division here at headquarters. Solange, lovely to see you. Over to you.
Thank you so much. Can you see my screen?
Yes, clear.
Yes, great. So hello, everyone. My name is Solange Carolina Alves, and I will be briefly talking during the next 5 minutes about antimicrobial stewardship, its definition, and the tools that WHO has in this matter. Before that, just to say that I'm really happy to be joining this webinar. This is a really wonderful initiative. AMR, it's really a threat to modern medicine, and nurses and midwives have a crucial role to tackle misuse and overuse of antimicrobials, since you are at the heart of health teams liaising with doctors, pharmacists, microbiology, and diagnostic teams. So this is really important. Antimicrobial stewardship and WHO definition. So we really want to promote the responsible and appropriate use. So this is the definition is the coherent set of integrated actions, activities to promote this responsible and appropriate use of antimicrobials, and also to improve this way the patient outcomes across the continuum of care. About the responsible and appropriate use of antimicrobials, this is about the use, the prescribing, only when needed, and in that case, the optimum drug regimen. So the correct drug dose, frequency, duration of treatment, and route of administration. These activities for antimicrobial stewardship should be complemented with enhancing access of antimicrobials. So when we really need to use them, they should be accessible, affordable, and quality assured. And also we want to prevent infections, either healthcare associated infections or community acquired infections. So for that, we would need to implement core elements of infection prevention and control, and also to enhance water, sanitation, and hygiene, and also to optimize vaccination coverage. With this said, WHO has instruments for addressing the antimicrobial stewardship. The policy guidance, WHO policy guidance on integrated antimicrobial stewardship activities was published last year. And we have published in 2019 the Antimicrobial Stewardship Program in healthcare facilities in low and middle income countries, also designated as AMS toolkit. So we have the links here below. This was published in 2019. We will be having, can you see my screen? Because I'm not, yes. So we'll be having an online training course hosted on an open WHO platform next week. WHO policy guidance is really a set of recommendations, evidence-based, to provide guidance on the implementation of AMS interventions at the national level. And the AMS toolkit is at the healthcare facility level. So provides a programmatic approach to promote responsible use of antibiotics, specifically within the scope of antimicrobials. This is the focus of this document, and in antibiotics at a healthcare facility level. The aim is to preserve the effectiveness of the existing antibiotics and also to increase the access of essential antibiotics. This document is divided into 6 core components: the identification of core elements at the national and at the facility level, also the planning of AMS programs and the performance of AMS interventions and their assessment, outcomes indicators, and to facilitate education and training. We have to combine this with other 2 resources that we have that will show access aware classification with the access, watch, and reserve group. This is the classification of antibiotics according to their level and potential to elicit bacterial resistance, being the lowest threshold with the access group, and also safe antibiotics, which are meant to be the ones that are used when needed most often, followed by the watch, and reserve group. And this should be also complemented with the model, WHO model list of essentials medicines. Both were updated last year. This is an example, and I think it's really practical and really useful to look more deeply into the AMS toolkit. And here we have 11 basic AMS interventions. The toolkit also addresses other AMS interventions in more detail. And so we have here 11, and I really hope that you can access this and other resources, WHO resources, through the link, and also the training package that will be soon at the open WHO platform. Hope this will be helpful and inspiring you to bring solutions to tackle AMR, either policy or practice level, because really we need to address and to reduce the inappropriate misuse and overuse of antimicrobials. Thank you for your attention.
Thank you so much, Solange, for that rapid overview of antimicrobial stewardship and the really broad set of activities that falls under that umbrella. I think that hopefully this and the resources that you shared will provide a lot of inspiration for people tuning in. We go now to our final technical presenter, who I'll ask to turn on her camera. And as a reminder, if you have any questions for Dr. Balki, for Dr. Alves, or Professor Alegranzi, who's joining, please post them in the chat, and we'll have some time for discussion afterwards. But without further ado, it's my pleasure to introduce our colleague, Professor Benedetta Alegranzi, who is the technical lead for the Infection Prevention and Control Hub and Task Force in the Integrated Health Service Department here at WHO's headquarters. And she'll be talking to us a bit about IPC, Over to you, Benedetta.
Thanks a lot, Jan. Could you confirm that you are seeing my screen?
Yes, we can.
Okay, that's great. So good morning, good afternoon, good evening, everyone. Really pleased to be with you today, and you will understand why I value so much to be able to discuss with a nursing audience and people. So I will follow my two colleagues who mentioned the importance of IPC and also the connection of IPC to antimicrobial stewardship with my presentation. And I would like to start with a definition, which I'm sure you know already, but there is an element or two elements of this definition that I really want to highlight for the relevance to this discussion today. So we define infection prevention and control as an evidence-based approach and a practical solution. And this is where there is a first connection really with your wording, the wording of the challenge. So it's a solution that you can adopt in this context, in the context of the challenge, designed to prevent harm to patients and health workers at every single healthcare encounter across the whole health system by stopping the spread of infection and antimicrobial resistance. So the second element I wanted to highlight is actually this every single healthcare encounter, because I really strongly believe that nurses in particular are those who are present almost in every single healthcare encounter with our patients or users of the health systems. So this is where your importance should be highlighted. And indeed, our goal all over the world is protecting patients and health workers' lives through excellence in infection prevention and control. And this is why I'm sure you remember we focused the hand hygiene campaign in 2020 and 5th of May on addressing nurses and midwives with this slogan, and the entire campaign, clean care is in our hands. So what is the role of IPC to combat AMR? It's very important to understand this simple concept, but which is quite articulated. So as you know, IPC is meant to minimize the spread of pathogens, whether they are resistant or not, but in particular, by reducing transmission of the resistant ones, it reduces the spread of resistance. But overall, whether it's resistant or not, it decreases the likelihood of infection in healthcare settings, and therefore it reduces eventually the need for antimicrobials. So through these different functions, obviously IPC is at the core of strategies to combat AMR. So we have identified 8 core components of IPC programs, which are really very important and have become the milestones for any program or activity at the national and at the facility level. And also we identified some minimum requirements for IPC programs to be in place in all countries. At the core of an effective IPC program, there is an IPC team, and in some cases only a focal person, and this person is often a nurse. So the role of nurses in this is central again. So when we did the hand hygiene campaign in 2020, we articulated our reasoning and strategic thinking around the role of nurses and midwives in implementing the core components. And we issued a document which is represented here and you can still find in our website. There are some core components which are more important in terms of the role of nurses. Certainly core component 1, which is the program. For the reason I just mentioned, nurses are most often the health professional designated as the IPC leads in many countries. Nurses are central to education and training of other health workers, and in the field of IPC, and Hanan Balki has already mentioned a document that we have available on the core competencies for infection prevention and control professionals. In addition, core component 5 is how to implement interventions and solutions of IPC at the point of care. And again, role of nurses at the center of this implementation. And finally, the core component 7 acknowledges the importance of staffing, appropriate nurse to patient ratio, staffing levels, for many reasons, but one of the reasons is this factor is correlated to reducing transmission of healthcare associated infections, AMR, and outbreaks. So we did many guidelines, but most importantly, we need to implement them. And so we developed many manuals and resources that are available for you, and also training courses that are available on OpenWHO, more than 20 IPC courses integrated with other priorities as well, such as patient safety and quality. So before I conclude, just wanted to highlight a couple of areas, because as I said earlier, what matters of IPC is mainly its implementation at the point of care. Its implementation within clinical practices. So one area we developed, and which is very relevant for you, I guess, is IPC embedded within maternal and neonatal care. So there are guidances, but also posters and also training courses that are available and you can find. And the second area is surgical care. It is complex to prevent surgical site infections. There is a need for many teams to be involved, including nurses in the operating theater, but also nurses in the surgical wards. This needs to be embedded within the surgical patient journey. And this is what we promote through a number of tools and resources. So I thank you very much for your attention. And because we really need to do a lot more, some data are still appalling, showing that, for instance, only 16% of facilities around the world really meet all IPC minimum requirements, or as you know, many nurses are forced to operate in facilities where there is no water or there is no hand hygiene facilities. This is 1 in 3 facilities around the world. This is why we need to be united for increasing attention to this topic and really to its implementation. So this is the focus for 5th of May this year, Hand Hygiene Day this year, to be united for safety, cleaning our hands, but also promoting other IPC practices. And you nurses and midwives are really centered to this concept. Thank you so much.
Thank you, Benedetta. And if I can ask you to stay on camera and maybe ask Hanan and Solange to come back as well. We have about 3 minutes for questions before we turn over to the next part of this program. And so I'm going to do my best to pose one to each of you, starting with you, Hanan. Question being, we know so many of the people turning in are early career nurses and midwives. And so if you can put yourself in the shoes of, say, a junior nurse who's trying to get this on the radar in your hospital, where do you start?
Great question, and I think the practices inherited in the work of the nurses and midwifery are already very much related and relevant to either mitigating multi-drug resistance, the resistance of pathogens, or enhancing it. So I think the first thing is for them to be conscious about the perfectionism and their work and their excellence in work in moving their patients, making sure how they take care of the dressings, for example, all of that, basic nursing work is really relevant to the AMR agenda, and them emphasizing on performing it well within their healthcare setting or communities is going to be extremely important. So linking their practices, their regular practices, to how that's affecting AMR. I think that's the first step.
Thank you, Hanan. That's well put. I'll move straight to Solange, actually, if I can pose to you a quick question. Can you give an example? So, I mean, stewardship cause is just such a huge area. Can you think of, one kind of concrete example of what a simple solution that a nurse might do in a hospital that would qualify as a stewardship intervention?
Yes. So there are, as I showed in that slide, the basic AMS interventions. Most of them could be really done by nurses, like seeing if the drug regimen is correct, like seeing the records, and also if the duration of treatment is correct, or switching route of administration from IV to oral route, for example. This is quite simple examples and linked to their practice, and they will be enhancing proper antimicrobial use.
Thank you, Solange. Well put. And Benedetta, last word to you with Hand Hygiene Day coming up and IPC having so many rich resources and a very clear to-do. What is the single biggest obstacle you see to IPC measures being taken up, embraced and sticking in facilities?
Well, as I said in my presentation, I think we have to acknowledge that there is an obstacle due to lack of facilities and supplies, no doubt, because, for instance, hand hygiene must happen at the point of care, and often there are no supplies readily available at the point of care. So that is certainly one point. But then I think it's really having a widespread awareness and also personal accountability throughout the facility, throughout teams, in order to understand that IPC is everybody's business, and it's really every single of us practicing at the point of care, being in contact with patients, in particular, like nurses do, have an immense importance and role in avoiding transmission. So this is about clinical practice, but many nurses are also leaders at the level of a ward or at the level of a facility. And so they are decision makers in terms of allocation of resources, advocacy, and decision how a facility should tackle the issue of healthcare associated infections and AMR transmission. So they have an important leadership role as well in highlighting this issue. And finally, I think another obstacle is the fact that issues like IPC, AMR stewardship, patient safety, quality of care, they are all connected. Surveillance, they are all connected to each other, and too often in the field, these various areas of work are dealt with separately or in parallel. So again, nurses can play a very important role in synergizing, in collaborating with different groups, and connecting the dots and really making collaborative work and integrated work, and avoiding duplications. Very important solutions. Actually, it's a solution.
Thank you for tying that all together, Professor Alegranzi, Dr. Alves, and Professor Balki. Thank you for that rapid crash course in AMR, antimicrobial stewardship, and IPC as well. I'm going to now hand it back over to Emily, who's going to walk us, introduce our case studies. If you have any additional questions, please do feel free to post them in the Q&A, and we will do our best to address those by text. Thank you.
Thank you so much, Leanne, and to your fantastic team. It's really frightening data when you start seeing the numbers, and I think the numbers that you presented at the beginning, Professor Borkley, were really mind-blowing, actually, and quite overwhelming to see the impact that this will have on human health. But I think what's really important is it's great to understand more about what we as nurses and midwives can do and must do, and that it's incumbent in our roles to be able to make a difference. So thank you for really spelling that out to us. I think it's really important. There have been in the chat box some fantastic resources. We will make all these available to you. I know they'll be available on the Nursing Now website, at the Facebook page, and also we will put them on our Nursing and Midwifery Global Community of Practice so that you can see, revisit this webinar if you want to, and access all the information that we've been discussing and talking about here. So don't worry if you've missed a bit or you've come late to the session, it'll all be there for you to review later. Before I move on, I just want to say thank you to Professor Alegranzi, because I think what you've said about having nurses and midwives as senior nurses with expertise in IPC is really important. During the COVID-19 pandemic, my most critical colleague was our IPC nurse, and I think we must never forget the importance of nurses and midwives having really specialist skills that they can really support training and teaching of our younger generation of nurses coming through, to remind us all that this is everybody's business and it's not just the job of particular people in hospitals. So thank you very much for particularly making that point. We are all leaders and this is really critical. And on the subject of leaders, which I'm now delighted to be able to move on to our second part of our session and to introduce Rita Akiki. Rita is the nursing director in the Abu Jadi Hospital in the Lebanon, has been a very, very active member of the Nursing Now Challenge already, and has already won a Global Solutions Award for her initiative in supporting newly qualified nurses. So I think we'll go straight over to Rita. Thank you very much, Rita. We're looking forward to hearing what you have to say.
Good afternoon. I'm proud to share with you our Lebanese solutions to fight the antimicrobial resistance. The antimicrobial resistance remains a global problem that is responsible for high rates of mortality and morbidity. Some numbers in Lebanon are very alarming. The SAR prevalence is around 30%. And the sensitivity of Pseudomonas to imipenem is less than 80%. At the national level, the Ministry of Public Health has launched in 2019 the National Action Plan on Combating Antimicrobial Resistance. But we all know that Lebanon is facing multiple crises. The 4th of August Beirut blast added to the economical crisis and the shortage in medical and paramedical staff. The antibiotics used in Lebanon at the level of the community are without a prescription, and in the hospitals we have more than 50% of the prescriptions are overprescribed for the patients. At the hospital level, we have since 2007 the Control of Nosocomial Infection Committee that is developing IPC guidelines, and since 2013 this committee is working on procedures to safeguard the most valuable antibiotics and to reduce AMR. Based on the WHO core components, we have launched awareness, education, guidelines, and others, of course, surveillance to be sure that our guidelines are attaining their aims. All is based on the nurses' advocacy for the patients. Here comes the role of the nurses. First, the WHO 5 moments for hand hygiene. It's a major IPC component. Nurses are adopting those moments. They are like soldiers to apply those moments, and they are looking after anyone who is accessing the patient room, the visitors, the patients themselves, and all the staff is educated about the importance of hand hygiene. Also, nurses are working on the isolation procedures. We have tailored our procedure and putting posters that are very simple to read and understand in the front door of each room where there is a patient in isolation. Like this, anyone who wants to access to this room is alerted before accessing and abiding by this procedure. Also, nurses are working on an early detection and identification of patients carrying multi-resistance drugs microbes. So in fact, when the nurse is doing her physical assessment and taking the history of the patient, if this patient is fitting the criteria, she's taking multiple cultures as by procedure, and she is putting the patient under strict isolation till having the results. So like this, we are working proactively and we are saving the patients, the visitors, and the other patients. Also, nurses are working in the raising AMR awareness by education, especially for visitors and for the patient himself. One of the major components of our guidelines is the restriction of the use of the antibiotic. And here comes the leadership role of the nurses. They have been empowered by the medical and the general direction of the hospital, and they have full authority to call for an infectious disease consultation when a physician that is not allowed to prescribe one of those molecules has prescribed one of them. So the nurse call immediately for the infectious disease that can come, see the patient, see the chart, and escalate, de-escalate, or even change the antibiotic. One major role of the nurses also is the active membership in the pharmacy committee and the microbiology committee. Like this, nurses can have feedback on their work and they can share all their concerns and upgrade the policy and up-to-date the guidelines based on evidence. The key success of all those procedures are the multidisciplinary approaches and the integrations of all the partners in our work, especially the implication in the empowerment of nurses, since the nurse is the patient advocate. She's spending all her time, day and night, near the patient. What we still have to work on is the transition between the hospital and the community, and in years to come, this will be our project. Thank you.
Thank you very much, Rita. That was really interesting, actually. I think what you showed at the very beginning was the impact of why so many factors contribute to making this an issue, not just those that find themselves in hospital. So thank you for a great presentation and for talking through your initiatives. It's really interesting to hear the impact of good communication with your public and visitors into the hospital. I'd like to ask you a question a little bit later about how you manage to get visitors to comply with infection control restrictions, sometimes quite difficult, but we'll have some time for questions afterwards, I hope, or please keep putting them in the chat box or the Q&A if you would like to ask any of our speakers any questions as we go forward. So I'm going to move on now to introduce Gila Zarbiv. Gila is a senior nurse midwife from Israel with a master's degree in women's health. She's the head midwife for infectious disease prevention for the labor and delivery ward in a hospital in Israel. And really interestingly, Gila was the midwife who delivered the first COVID-19 positive birth in the country, the first COVID-19 baby, and has been the head midwife ever since for leading the COVID-19 management protocol and implementation in a hospital. So Gila, thank you very, very much for joining us, and over to you.
The pleasure and honor is all mine. Thank you so much to the Nursing Now Challenge and to the WHO. This is such a crucial topic, and it is an honor to be here as a midwife from Jerusalem, Israel. To join together on a global scale is overwhelming and truly an honor. This is a very close concept to my heart. Develop a solution that tackles the misuse and overuse of antibiotics. It is not a simple one by any means. And I think that the more that we work together and collaborate, the better it is that we're going to find solutions. I had a lot of things I wanted to talk to you about today, and we could do this forever, but I have 5 minutes. So I decided that we're going to talk about group B streptococcus. And we were discussing different bacterium and different problems. And I think that GBS is a great example of a big problem that has small solutions, and we can make real change. So it's a group, GBS is a type of a bacterium. It is one of the leading causes of neonatal infectious morbidity and mortality globally. It colonizes in the gastrointestinal or the general urinary tract of about 25% of pregnant women, and it causes approximately 0.49 per 1,000 cases of morbidity and mortality worldwide. So it's a big problem. But GBS is fascinating because on the one hand, it's a colonizer with no symptoms and no problems, and it can also be a potent pathogen. So it's like this issue we have. It is the babies are infected in uterum, or which means in the uterus, or at birth when they pass through the vaginal canal and they become infected with GBS. There are no global standards of how to screen for GBS, but women who are recommended for screening in countries that recommend screening do vaginal rectal swabs or urine samples. And the treatment is penicillin, which is part of our topic today, antibiotics. And the research shows that ever since we've introduced this penicillin, we've had significant impact on neonatal morbidity and mortality. We've saved countless babies' lives. So this is important. So let's just give every woman antibiotics. What's the big deal? If this is so serious and so many babies are dying, then let's give every woman who comes to the labor and delivery ward antibiotics. Well, it's not that simple. The research shows, and I brought one example, but there's countless articles. The research shows that we do this screening for the women who do screening. We do the screening from week 35 to 37. And the articles are showing that some numbers were as large as 60%, but the numbers don't really matter. A certain amount of babies that at the end got sick with GBS, their mothers screened negative when they were tested from 35 to 37 weeks. And another large amount of them, the mothers who were positive, when they showed up for birth, they were negative. So what we're seeing is that GBS is dynamic. It changes. So what you understand now is that a certain amount of mothers who need antibiotics are not getting it, while another amount of mothers who don't need antibiotics are getting it. So we have issues here with validity and reliability. The test that we're doing might not be so valid, and it might not be so reliable. So what does that do? Well, the research shows it does a lot. Prophylactic exposure to antibiotics for GBS has significant impact on the baby's microbiome. Now, microbiome is a word you're going to hear a lot. I personally believe that we are leaving the realm of antibiotics and entering the realm of biotics, but microbiome are the healthy, important flora, are healthy, important bacteria that we need. And we're causing real change to these tiny babies who are essentially sterile and need access to these crucial bacterium. We're causing serious change to the mother, to the baby, and to the breast milk. We no longer talk about the mother-infant dyad. We now talk about the mother-infant breast milk triad. So let's summarize. GBS is bad. It exists. It can do a lot of damage. We need to get antibiotics to people, but there's a problem with the reliability and the validity of the test, and it has potential risk for AMR. So what are our options? We have a few options. Option number one is we can start doing a PCR. We all now know what PCR is. When a woman shows up, we no longer screen early, test her when she arrives in the labor and delivery ward. That way we can catch the women who actually need antibiotics. Or there's development of vaccines that have been going on for many years. Hopefully one day we can develop a vaccine. But of course, these solutions cost money and manpower, and it's not that simple. So what can we do? The nurses and the midwives, who are the first and last line of defense. We are the first ones to see these women, sometimes the only, and sometimes the last. What can we do to make real change? It's actually not that complicated. If a woman comes to you and her water has broken and she hasn't tested GBS, test her. A lot of hospitals will start giving antibiotics after 18 hours of a woman's water breaking if she hasn't been tested for GBS. If you test her, maybe you can prevent that. The other thing is, we need to know about it. We need to know that this test might have issues, and maybe we need to start making some changes. We need to talk about it. We need to collaborate with each other on a global scale and talk about maybe solutions and implement those solutions. But the simple things that we can do as nurses and midwives is give that mother and baby skin to skin and not separate them. Keep them together. Give that baby access to that crucial microbiome on the mother's skin. And of course, breastfeeding. These sound so silly, but they are so crucial to giving the baby access to the crucial microbiome that he may need, especially in cases where the mother received antibiotics, because these things can make huge change. And the bottom line is that change is in our hands. They say that the first step of 1,000 miles started with one single step. We have the ability to make huge change by just doing skin to skin, breastfeeding, being awareness, and collaborating. Thank you so much for having me. It was an honor to be here. Have a great day.
Oh, thank you so much, Gila. What an important message, actually, that sometimes the big solutions can be very simple. And as nurses and midwives, I think we've all had experience. I'm sure many of us have had experience of sick babies. And if we could change that by simple measures, we must learn from that. So thank you so much. Really interesting, great presentation. So our final speaker today, delighted to introduce to you Nikwan Jacob. Nikwan is the infection prevention and control nurse at the Baptist Training School for Health Personnel in Cameroon. Nikwan has implemented a fantastic long list of infection prevention and control initiatives, and I'm really going to hand straight over to him because I want to hear about them. I'm sure you do too. Thank you very much, Nikwan, and over to you.
Okay, good afternoon, everyone. Welcome from the different countries. I am Kwan Jacob from the Cameroon Baptist
Thank you, Emily.
Good afternoon, everyone. The surveillance of cesarean section, healthcare associated infections, and the antibiotic use in Bansal Baptist Hospital. Healthcare associated infections are common adverse events in different countries, and they seriously compromise the quality of care and leading to serious consequences to staff, the healthcare facility, as well as the entire community. And they are actually responsible for driving the use of antibiotics and promoting resistance in the different countries. I will be talking about a study that we conducted in Bansal Baptist Hospital Maternity. The aim was to determine the incidence of cesarean section surgical site infections, as well as evaluating antibiotic prescribing practices. It was an observational prospective cohort study conducted between the period of 24th of May to the 3rd of July 2021. And it included all women that delivered through C-sections in the facility. Bansal Baptist Hospital is a 330-bed hospital. It's a tertiary referral facility run by the Cameroon Baptist Convention Health Services, and it is located in Bui Division of the Northwest region of Cameroon. The results of this study indicated that we had 4 out of 22 participants that were enrolled for the study developed infections, resulting in an incidence of 24 new infections per 1,000 patient days. And those that had infections, they stayed in the hospital 16 additional days, leading to additional expenditure related to additional care, as well as additional length of stay. And in relation to our topic of discussion today, the most interesting finding is that all the 22 participants received 1 dose of antibiotic prophylaxis before the first incision, and they continued with the antibiotics post-operatively for 1 to 2 days. And then in this study, 82% of the participants were discharged with antibiotics, which was not necessary, meaning that there was irrational prescription of antibiotics. And so to conclude, we want to say that healthcare-associated infections serially compromise, and they are responsible for driving the use of antibiotics, which also increase the risk of resistance. Surveillance and infection prevention are key strategies to prevent healthcare-associated infection, and by extension, they are also the best strategy to reduce the use of antibiotics, as well as preventing resistance in our healthcare facilities. Thank you for your kind attention.
Thank you very much, Nikwan. Really interesting. Surveillance, so important in the work that we're all doing. Apologize to you all for the sound quality in the middle pit of that. Nikwan's, we were trying to just make sure that the Wi-Fi connections were strong. If you look at if you want to review any of the talks and speeches today, then they'll all be available to you through the Nursing Now Challenge website or the Nursing and Midwifery Global Community of Practice at WHO. And I noticed both of those links have been put in the chat box there, so you can join and listen again if you didn't catch the middle part of that presentation. So I'm just mindful of the time now. I'm wanting to say a very, very sincere thank you to all our speakers today. There's an absolute wealth of information that has been addressed. Lots of questions I'm sure you'll have in your minds. There's nothing active in the open questions in the Q&A box just now. But if you do have questions and you haven't been able to ask them, again, please put them forward through the Global Community of Practice or to Nursing Now, and we'll endeavour to answer them and get back to you a little later on. So what I'm just going to do now is remind you all of the challenge itself, and hope that through the sessions and speeches that you've heard today, you've been really inspired to come up with your solution, and will enter this into the challenge. So just as a reminder, in your role as a nurse or a midwife, develop a solution that tackles misuse and overuse of antibiotics. That's the challenge. It's been mentioned several times, and I hope you've had some really good suggestions today about how you might address that in your own clinical area or your place of work. I'm just going to remind you of the instructions. These are all available on the website or through the Nursing Now Facebook page. But we will have one more session on the 6th of May, just before International Nurses Day. So I hope you'll be able to join us for that. And during that session, we'll hear some case studies from you and from other members of the Nursing Now family about solutions that they've already implemented around the world that have made a difference to AMR. So do join there if you want some more inspiration, or you want to hear what our colleagues and family are doing around the world. I'm sure that will be a really interesting day. After that, we then ask that you write down your solution and your plan, and you submit it to the Nursing Now website at the latest by the 30th of May. So that's the deadline, end of May. You need to send it to info@nursingnow.global. All those information again, and the email address available, as I said before, on the website. Really important day I want to talk to you about now is that the final session that we'll be hosting as part of this initiative will be on June the 22nd. And what we'll do during that webinar is that we will hear the presentations from the 3 best solutions that have been submitted. So if your solution has gone into the top 3, we'll contact you before that date and let you know. At the end of that session, our Director General, Dr. Tedros, we hope will be able to join us, and will announce the winner. So a really big special moment to be able to be part of. So I do hope you'll be able to join that 22nd of June. And then just to highlight the all important prize, The prize itself will be that you will have made a huge contribution to global health, to the solutions for AMR. So something very, very important and special to be part of there. But in addition to that, the Nursing Now Challenge will be donating £1,000 to support your solution and to get it off the ground. So a real investment for you to be able to spend on getting your work into practice. And then we're going to invite you to present your solution to the WHO experts. So the team that have been involved on our webinar so far, our wonderful AMR division, the panel, and hopefully we will also be able to include the Director General, our Chief Nursing Officer, Elizabeth, will be there, and of course, the AMR team to listen to your challenge, your solution, and to offer advice and support into how you can implement it and make it a reality. So a really, really great opportunity to learn from the experts and get their input into your solution. So we hope that that will be something that will inspire you to take part. We are then going to help you to publicize your solution. We will support writing it up in a publication. So we will co-author an article with you about your solution and the challenges of implementing it. So we hope that that's something that will be really exciting for you as well. And we're looking at an option to be able to present this to the Director General at one of our WHO press conferences. So some really great opportunities that will arise from putting in a fantastic solution to us. I really, really hope that you will do that. I think it's really important that when we sit here and we listen about things and we think, yes, I think I'll do that. I think I'll do that. Actually do it. It's really, really important. This is a massive issue for us, for the world, for our patients and for our whole human health. So if you think about doing it, please make sure that you do. Now, just before the final end, I'm just going to hand over to Elizabeth. Elizabeth, thank you for staying with us. And I think you have some final remarks just to add to our challenge today.
Thanks, Emily. Not too much I know we've gone a little bit over time, but I just really want to just briefly say thank you to our experts and also to our panelists, for again, another really informative session. Really excited to hear what's happening out there at country level. Thank you for sharing your resources and materials and the experiences that you've had in leading the work in your countries. And I know, as you said, Emily, I think these two sessions definitely lends to support those nurses and midwives who I'm sure are excited to undertake the challenge to develop initiatives to reduce this inappropriate use of antibiotics in their places of work. So thank you very much to all who have joined us as well. And I look forward to hearing some of you make your presentations in the next session. Thank you.
Thank you so much, Elizabeth. It's great to have you with us and supporting this fantastic plan and initiative. So that remains for me just to say thank you to all of you for joining us, all 600 and something. I hope there's many more of you going to watch this later. Remind you, the next session is the 6th of May. In the meanwhile, I'm going to say it one more time. Don't just think about a solution, please create one. We will not solve this if we don't all play our part. So on that note, I'm going to leave you. Thank you very much and enjoy the rest of your day. See you next time.